I have the pleasure of introducing Dr. Hawk today from the Department of Surgery here for Internal Medicine Grand Rounds. He came to us from his surgical training at State University in New York, and then he did a fellowship in hand and upper extremity at the Christine Kleinfeld Institute. And then he did another fellowship in plastics and reconstructive surgery in St. Louis University before he joined us in 2009 as a clinical assistant professor in the Department of Surgery and Plastics. And he's here to talk to us about the surgical intervention in migraines for our difficult migraine patients. So please give him a warm welcome, Dr. Hawk.
Oh, thank you. Thank you. So this first picture is my first day of work. And I thought I'd join plastic surgery and I will have the fancy office. And so I had to take this picture, and I've been showing this picture because I'm not sure I will ever find this again. So I go inside and I'm talking to Rich, and he says that I'm like all pale. He's like, "What's wrong?" I was like, "This is the office." He's like, "Oh, I try to fancy it up by putting this sign for you because you might be lost." So this is the upgrade from what he had. And he's like, "Oh, don't worry about it. Oh, by the way, I'm leaving for next 2 weeks to get married, as you guys know, with Monica, in like multi-continental marriage thing." And he's like, it will only get better. And he has been right, as he usually is. This is the agenda for the talk. For most part, this stuff I think most of you guys know a lot better than I do. But I think just for completeness sake, I will cover that up in pretty briefly, in part because I don't know much about it. But this migraine surgical treatment is one of the more fascinating things that happen in plastic surgery, at least as far as I'm concerned. And I think the evidence is probably stronger for this surgery than even carpal tunnel, which we do a lot of it. And we say that in plastic surgery, there are two kinds of surgeons. One run away from nerves, and one kind of go towards us. With me and Rich both being trained in hand and microsurgery, we do a lot of nerve surgery. So obviously, that does make us more comfortable dealing around the nerves. I think something happened here. I'm sorry. So in plastic surgery, the ultimate part is when you have reconstructive surgery and cosmetic surgery matched together. And migraine is probably one of the best examples we have, where as I'll tell the story of how this whole thing came about, that it was a cosmetic procedure, and somebody noticed that there was something different about these patients, and then now it's part of the reconstructive surgery. At the same time, depending on how you do the surgery, there's some cosmetic benefit, which never hurts, as I learned. Just to kind of cover some basic facts, as you guys know, it's a huge problem. 28 million people, and $14 billion on migraine, work days lost, and 19 disability. It's a huge problem for our patient population. And this is where it gets more complicated for me, because there's multiple types of headaches, and I think before we can treat anything, as you guys know, we have to first diagnose it properly. And I think that's where I think we can make or break any surgeries by not properly selecting our patient population. So if I start operating and start putting a billboard sign saying come to me for migraine surgery, I think I'll probably not get good results. In part because I won't be able to differentiate all these types of headaches, and I think that will ruin the results. And I think that's one of the lessons we have learned from Dr. Guyron. I'll show you who he is. And obviously there's multiple secondary headaches, trauma, vascular, surgeons being another cause of headaches. So migraine with aura is, and this is the latest classification as far as I can tell, where you need to fulfill a couple of criteria for it to be diagnosed as migraine at the very superficial level. It has to be, it has a duration, location, where it has to be unilateral, pulsating in nature. And obviously, these are the inciting factors. Walking, climbing, light is a very common inciting factor. And it has to be, you have to have one of these symptoms, nausea, vomiting, and there's multiple other symptoms. I just kind of picked the more common ones. And then you have to rule out other causes. Aura, just definition-wise, it's just it's a neurological symptoms, and that people have described all kinds of different things that they see when they have the aura. But more common one is flickering light spots in the line or blindness. You also have dysphagia, vertigo. And this where, again, becomes even more complicated, the pathophysiology of migraine. I think the short answer is we don't know. And I think the long answer is these all have been proposed at one level or the other. And I don't think anybody can for sure say this is the more, and I think the answer is probably a combination of these things. Because I think migraine is probably more complicated than we appreciate. So obviously there's the hyperexcitability of a central neurons. You have a cortical spreading depression, and that's the mechanism proposed for aura. But the one I know most about is that surgical is the trigeminal nerve irritation. So our proposal, this is not what plastic surgeon came up with. This is one of the proposed mechanisms. We just have found a way to treat it. And the idea is that the compression, like your carpal tunnel, once it gets irritated from compression, you have central, you release neuropeptides, and you have local meningitis. And if you can stop the inciting event, you might be able to treat it or at least decrease the symptoms. And that's where this came into play. So the vast majority of patients, probably 95+ patients, will be treated by oral and parenteral medication, which probably is still, it is the standard of care. And I don't think anybody is suggesting that every patient should be seen by a plastic surgeon or any surgeon for treatment. I think only patients who are difficult or not being treated or they cannot stand the side effect of medication, I think those are even candidates for surgery, much less they would get treatment. And I'll tell you the selection criteria. Botox actually is FDA approved at this time for migraine, and but their treatment for which it got approved is a little different than what I'm going to propose, at least, and then surgical treatment. And I put this is a busy slide. There's nothing to, only reason I put it up there is to kind of show you that there's no one drug that works, or even one mechanism. You have calcium channel blockers, you have beta blockers, you have antidepressant and anti-epileptic medication on this list, and this is the standard of care. So I think it just kind of goes to show that we don't know the mechanism of why migraine happens, and we try different things, and different people are affected differently. And this, again, a busy slide just to show you that even the medication which are very effective have significant side effects. So you might have a patient that his or migraines are controlled, but because of side effects, they cannot tolerate the medication, the first-line medication. And that's common for a lot of the medications that are pretty effective. And obviously, there's a cognitive part and behavior, biofeedback, relaxation technique, which have some proven benefits, and avoidance of trigger, caffeine, alcohol, tobacco. So just to kind of start for where plastic surgery came into play, Botox was initially discovered in 1896, so it's been around for a while. And as you can see, there's multiple distinct neurotoxins. Only the A is the one that we use for cosmetic or therapeutic purpose at this time. Was first injected in 1977, and the first cosmetic use was by Dr. Crothers, who was an ophthalmologist. He used for strabismus, for eye disorder. In April 2002, it was approved for rhytids or wrinkles, and Botox at this time is the most common plastic cosmetic surgery procedure we do, and its rate has been growing up by more than 1,000% for the last 10 years. And it's phenomenal how much Botox people, and finally they actually have a competitor, so the price should come down at one point. And in 2010, FDA actually approved Botox for migraine. The significance of this is that now insurance will approve, because a lot of people are paying out of pocket, and you need significant Botox, and very often for it to be treatment. So now insurance, not all of them, obviously it's going to be a fight, but insurance starts approving for Botox for migraine, which obviously helps. So how does it work? As I think most of you guys know, it's the neuromuscular blockade. It's a temporary onset is 24 to 36 hours, peak is 7 to 14 days, and lasts 3 to 6 months. So it's reversible, which is one of the benefits of Botox is it's reversible. One of the bad things if you have migraine and you have a lifelong disease that you need every 6 months or 3 to 6 months that you need treatment for. So how did it all start? Excuse me. So Dr. Gairan, he's a chairman at Case Western. And him, like a lot of plastic surgeons, he performed a lot of forehead lifts. So this is what happens with forehead lift. your wrinkles in the top of your head and this glabellar area, you take out some of the muscle release, and then it smooths out the forehead. And in this surgery, part of the treatment is the two nerves that come up here, you go around the nerves to release the muscle, just so you can cut the muscle. So before they were not releasing the muscle, they were just avoiding the muscle, and they were dissecting it out. And like a lot of discoveries in medicine, thousands of patients have been done by this, but only at least as far as we can tell, Dr. Garner was the first one to notice that some of his patients were saying that migraine got better. And I think most people just kind of ignored it. They're like, whatever. But him, being in academic centers and having a plethora of residents and fellows do his research for him, so they did retrospective chart study. And they found that 31 of the 39 patients had migraine improvement in their retrospective study. So it kind of shows that they have detailed records. And he noticed something that other people obviously had missed before. And then I think this is one of the more remarkable studies in plastic surgery, as far as I can tell, that he has gone methodically to prove that this is scientific, not just a side effect or a placebo effect. And so after that, then they were like, okay, where were these people complaining of pain? And they found 4 trigger points. And one of the things we are learning about migraine, and this, as you can see, the study was in 2000, so it's been 12 years since the whole thing even started. And there's been a progression of our understanding of how to treat it, how to diagnose it. And I think, obviously, the story is not complete yet. But so they found 4 places: frontal, temporal, occipital, and septonasal, which were the common places people complain of where they felt the migraine started. And then they went about designing a study. And just to kind of get everybody on the same page, for frontal, they noticed frontal pain. They had strong moving muscle, a frown line in their glabellar area and in between the eyebrows. And they had some ptosis of their eyelids. In temporal area, they had TMG pain, or a lot of people complain of grinding of pain, grinding of teeth the night before. In their occipital, on the back of their scalp, they complained of neck stiffness and pain, tenderness. And this septonasal area, they complained of pain behind their eyes. Only thing common between all these trigger points are these are where the trigeminal nerve provides sensation. So this is all facial area, and they all are different branches of the trigeminal nerve. And that's the common defining criteria, theme behind all this stuff. All these trigger points are. And just for illustrative purposes, so this is your supratrochlear nerve, and this is supraorbital. And this is a little more detailed anatomy. These are the muscles that we cut when we're doing forehead lifts. And you literally just cut it out and then it smooths out. These are eye depressors, so it actually lifts up to your eyelid, so there's a cosmetic effect to it. And you cut this, posterior is the one in the middle, corrugator is the one that kind of goes around a little bit here. And that's a little more detail. And this is a proposed area where people give Botox, and the idea that you give Botox, muscle gets paralyzed, decreases compression, and then you go about, if they have benefit, then it works. Zygomatic temporal branch. This is one of the branches we used to resect routinely without even knowing it. In our facial fractures, when we are dissecting up here, and there's multiple overlap of sensation in this area, so there is no ill effect that people knew. So we used to, in my training, I still do, and when we were elevating off the muscle, we used to elevate it all the time without knowing it. Now we actually look for it in temporal, but you can see how temporalis muscle compresses this nerve. And this is one of the only nerve that we resect because the symptoms are so few. If people have asked, why can't you just cut the nerve? Well, then you have numbness in your scalp, and it's kind of weird when you comb your hair, and it's actually pretty disabling. So that's why we don't resect it, and we decompress it. Versus here, I think the numbness is not noticeable at all, and we've been doing it for a long time, so these are long-term studies. Occipital is the back, it's the greater occipital nerve, and you can see the spinalis muscle kind of encompasses the nerve, and this is the area, and this has all been pretty well defined in anatomical studies coming out of UT Southwestern, where they've done a lot of cadaver study to define exactly where the nerve is. It's like 7 millimeter up and 1.5 millimeter up from the neutral ridge, and then you can find exactly where to inject. So this has been pretty well defined by now as to how to treat it. And the septonasal, just the baseline anatomy, since it's not a common area a lot of people see, your septum actually is cartilage, and the top part is bone. having septal deviation is not uncommon at all. So when people want, they used to want rhinoplasty, they're like, oh, I have deviated septum. Well, everybody does. So that's not really uncommon or symptomatic. And the other part is your turbinate. This humidifies your air that goes in your nose, so that's pretty common. So what they found was that if people have this CT finding or on exam where you deviated septum, or if you have hypertrophy of this concha, and there's multiple etiologies why you might have that. If they have contact, those patients presented with eye pain as their trigger point. And so for this, I'll kind of suggest a surgery. It's kind of standard rhinoplasty surgery that we do. The other part interesting part for migraine surgery is all these procedures that I'm going to describe for release of this treatment is already used for cosmetic surgery. So this is not a new surgery, it's a new indication for surgery. And the other benefit, in my opinion, is that cosmetic surgery by definition has low complication rate. You cannot do a cosmetic surgery with 10% complication rate. You're not going to be a very popular surgeon. You have to have a very low complication rate for that to become a routine cosmetic surgery procedure. So Dr. Garan went about, this is 2001. He did a prospective study, took 29 patients. He works with a neurologist, and he established a diagnosis of migraine. Then they injected Botox in 22 out of 24 patients who benefited from the Botox. They offered surgery, and I'll show you the surgery they offered. And they had 21 out of 22 had observed improvement. And that's where it becomes, when people say, what improvement? Well, they define it as more than 50% improvement or elimination. And they kept meticulous diaries of how many migraine you're having and how often are you having and the intensity. And then they compared it. So obviously I couldn't put all the data in there, but they have meticulous data showing that where it's come from. Of course, people complain that it's a prospective study, small patient population. It doesn't mean anything. It could be. So this is one of the more remarkable studies I have ever seen in surgery. This is a placebo-controlled surgical trial. So these people underwent sham surgery. How he got approved in 2009 by IRB is beyond me. So he had people undergo surgery without release of nerves. And so they underwent general anesthetic and sham, so they had incision without any release. Again, I think you cannot find better study, placebo-controlled trial than this. At least I don't know of any in surgery at this point. And they identified and they went through the same criteria. They gave Botox, and they said, okay, this is a trigger point, and they went and released it. And what they found was 83% of the patients had benefit, obviously defined as more than 50% improvement in their symptoms. And 57% had complete elimination. And I think this is one of the kind of turning point where migraine went from being a fad to where there might be something to it. Obviously, there are people, anytime something new comes in, people are always like, oh, maybe this is, maybe it's the person doing it. There's no long-term studies. So he went and did this 5-year outcome study. And I don't know how he keeps these patients around for them to give this data, but these 100 patients treatment group, obviously this is still pretty good follow-up for 5 year. And now he actually has 10-year data that's not published yet. But I actually went to Cleveland Clinic to talk to him and take his mini course, just to kind of talk to him in person. And he has 10-year data which shows the same thing. Obviously the follow-up is not as good. You just cannot get that many people to come back to you. 80%, 88% with positive response, and almost 30% with complete elimination, and 50% reduction. So we have short-term, long-term placebo-controlled trial. And obviously there's a lot of data up there, but just to kind of show you, highlight the area, that baseline they had 10.9 headaches per month. It went down to 4 at 1 year and 5 year. Other part is, for most part, in 30% of the patients, they release 3 trigger points, which is important because as they're learning, if you just release one, your trigger point might move, and then your failure rate kind of increases. And this is the chart that shows you the complication rate has to be very, very small for this to be effective surgery. And we have long-term data from our cosmetic procedures showing that this is pretty hyposensitivity, hypernumbness. Anytime you work around nerves, you have some temporary area. He had some bleeding from his nose, which is again, anytime you do rhinoplasty, that's one of the main complications is septal bleed, and they were able to complicate. There was 3 patients in that study. So, but overall, I think a pretty low complication rate. then obviously people said when only Dr. Gairan can produce this result, that's really not any surgery that only one person can do, that's not really very effective. So I just picked one study. Obviously, he has the largest studies. He obviously has the biggest database of anybody out there. So this is an earlier study. This is from George Washington, where they did 18 patients, and they had pretty similar results to them, to Dr. Gairan's studies. And there's multiple studies now coming out showing the very similar data and results. Obviously, they don't have as large number of patients as Dr. Gairan does, for obvious reasons. So this is the algorithm that he used it. And as you can, as I go further in my study, in this talk, I'll show you that this algorithm is changing as we all are learning more about this treatment. So you establish diagnosis, and like I said, this is if your other treatment options are viable or they're effective. I think that algorithm for surgeons kind of stop at that point. It's only people who are not getting benefit or they're still having significant symptoms or side effect that they come into this group. And I think then they need to be managed in conjunction with surgery. And then you find that trigger points, and if those are the trigger points that you can treat, then you do migraine surgery. Then I think you can get decent result. Otherwise, I think you're going to get bad result. If you start treating a lot of these patients, I think first of all it's not indicated, and second, I think you're not going to get good treatment outcomes. So at ECU, we're trying to establish a migraine center as part of it. And what we have proposed is work with people who actually treat migraine, establish the diagnosis. This is the most important part of it. We cannot get good result if you don't establish good diagnosis. And anytime you establish something new, you have to have data. And migraine patients are so, like at least the ones I've met, this is so disabling. They're more than willing to keep diaries, and they're probably one of the more helpful patients and more compliant patients that I've met, because if you tell them if you don't keep your diary, there's no surgery. I've seen a lot of diaries. Then you identify the trigger points, give Botox, and I'll show you this step can be skipped now according to the new data. And obviously our plan is to decompress it and then see our results. Now if you're not getting the same results that Dr. Gairan and other people are getting, then I think obviously we have a problem. So that's our plan, or at least proposed. Again, a busy slide. This is the original article that came out in 2005, where they will inject one site, wait 1 month, see if they have any benefit, and then go to the second site in a systemic manner. So you identify all the trigger points. As you can see, this takes a long time, and most people are not, especially for Dr. Gairan, a lot of his patients come from outside. This is not very practical. But when I was talking to him, he says, whenever you start something new, and that's something different, and it involves some cosmetic surgery, you have to be very methodical for people to say this as being a scientific versus a sham way of getting a cosmetic surgery for reconstructive purpose. And I think, so this is the reason I think he went in a very systematic manner, trying to show how you can, you can see site B, then site C, and then you keep going down till you have identified all the trigger sites, and then do your surgeries. This is a paper from 2012. This is like last month. And what they found was they had obviously 207 patients in a patient with the Botox group, but they also had 90 patients that they did not use Botox at all. They went by their symptoms, and there's a list of symptoms, like some of the symptoms I described earlier. And if they had diagnosis of migraine and they had the right symptoms, they operated, and their results were not much different, 80% benefit and 32% with complete elimination. So this is obviously just like last month. So the paradigm might be changing as we are talking, that we don't need Botox. And I know some of my friends were actually just injecting. So when you have a patient come with migraine, and if you can find the trigger point, just inject lidocaine. And if the lidocaine numbs that area and that migraine gets better, their efficacy of that is almost as good as Botox. So it does cut down the time frame when patient can get surgery. And again, this is data showing that you can get good results as long as you are meticulous in your history. This is obviously the surgeon part of me, where I have to kind of show you what we do and why we do it. And this is pretty short, but I'd be more than happy to talk about it in detail, ad nauseum. So this is the forehead. So this is the standard forehead surgery we do. We can make a cut around your hair, in your scalp, depending on how much skin you have. Obviously, if you make an open incision, you have better exposure, or you can do it endoscopically. You make 3 incisions, or in your hairline, and then you can release, do the same surgery. Or there's the third part where, if a young person, like 28-year-old person, she doesn't need any forehead, you can go in their eye crease where you do your eyelid surgery, and you can get to the muscle from that way. So depending on the patient and your indication, you can do different ways. Obviously, if you have an older person who wants some forehead lift at the same time, that doesn't hurt ever for a patient, and does make it more palatable for a patient to undergo surgery if they can get forehead lift in the same time. This is probably I've never seen this good a picture, so this is from an article, endoscopic, because usually you don't see that. You have to go looking for, this is such a small nerve. There's a vein right beside it that bleeds usually, so by the time you get to it, you never see this such a nice nerve going through. So but basically you go up there, endoscopically resect, and that's it. So you can do that, or you can do open surgery. Obviously you can see it pretty well. And how do you know that's the right nerve? It's the location. You have to know the location in anatomy to know that's the nerve you can cut and other nerves you can't. So you just resect, that's the only nerve you resect. This is the back of your scalp, and this shows you the muscle, semispinalis muscle going across, and how you can release that. And you can see how the compression, this could be part of the compression for the nerve. And this is very similar to what we see in carpal tunnel, cubital tunnel, and other places we do nerve decompression. And this is obviously open exposure, and does require you to be in prone position. So that's a lot of work, but I think that does help. And again, this is a standard surgery for somebody who has septal deviation. What you do is you just take out part of the septum. As long as you have this strut, which is we know from, again, long time having done this in plastic surgery, as long as 1.5 centimeter each side, nasal support is fine, and there's no complication. You can do it fine. We routinely harvest this cartilage for our reconstruction purposes. So this is kind of standard what we do. And obviously for your turbinate hypertrophy, what you have to do is take out this part of the bone, and you can do it open or endoscopically. And again, it doesn't have any side effects. I mean, long-term side effect, again, having done this for a long time for patients who have this hypertrophy there's again multiple reasons for it. But you just take a small bone and let this kind of heals up. One of the main problems is we used to basically cut out this whole thing, and they had a lot of crusting and bleeding, so we kind of realized that's not a good idea. So now we just take small bone and leave most of the in, and it kind of heals up pretty well on its own. I think in today's talk, we cannot finish our talk by ever not talking about the cost. And I think and this study is actually not published yet, but he has this data on the online right now, and it's been accepted for PRS, it's just not been published yet. Obviously there's a lot of fudge factor, like how do you come up with these data numbers, and he has what he comes up with, and people can argue with the number, but I think the more important part is that there is a difference, that is surgery is cost effective, and I think as surgeons, if you cannot show cost effectiveness for a procedure, it's never going to be popular with insurance companies ever. Part of this charges, it involves everything including surgeon's fee for insurance purposes. So most of surgeons, actually they did a study showing if plastic surgeons will be willing to do this surgery, why not more people are doing this surgery? And one of the reasons was because insurance is starting to cover it, and you can charge a lot more for this procedure if you did that as a cosmetic procedure than as if you did that as a reconstructive procedure. So it's actually beneficial for a plastic surgeon not to have it covered by insurance, because it actually pays a lot better than, I think this is for all hospital costs, anesthesia cost, and surgeon's fee was $8,300. So I think that's pretty cost effective, and this is a long-term data. It's only 1 year. You can imagine at 5 years, the difference will be even more cost effectiveness. I think I leave this talk pretty short for most part, because usually I get harassed by most people saying this is not science. But for most part, I think this is a new paradigm. This is the first time that I know that how do you treat migraine with a peripheral nerve surgery. Again, I'm not suggesting that this is the treatment for all your migraine patients, and I think but I think that's one of the things people always like, what about this patient? Well, it depends. There's only a few patients. If you, like any surgery procedure I do, like we talk about the residents all the time, my outcome is directly related to how I pick my patient. I think part of my success or failure any surgery is based on way before the patient comes to the OR. It's based on what I see in the clinic or in the ED or whatever. If I don't make the right diagnosis, I'm not going to have good treatment. And I think that's the same way in migraine, no different. I think that's just another thing we can add to our treatment for migraine for some of our population. Again, like patient selection for surgeon, this is the like a holy grail. We kind of drill that in throughout our residency and fellowship and after that. So, and as you can see, the data is still changing how people are treating it, and it keeps updating. Thank you.